Welcome, everybody. Welcome to this session on Safety 2. My name is Leistikow, and I will be moderating this session. There will be three speakers who will introduce themselves after my short introduction. The speakers are Mary Patterson, Jeffrey Braithwaite, and Axel Roose. And in the background, I am being helped by Laura Yearsley from NHS Improvement. She will be monitoring the chat. And Hannah Westwood from BMJ is also moderating this session and will help put you all in breakout rooms at some point. This presentation will be consist out of three sessions, three-part sessions. So it will be three elements of Safety 2 that we will dive into. We will show a short video of somebody who's actually doing something with this part of Safety 2. And then breakout sessions so that you can discuss with each other what you have just seen, heard, and what your own experiences are. So about these breakout rooms, I know that many of you are not native English speakers and might feel a little bit shy to contribute to breakout rooms. I am not a native speaker either, so I understand this feeling. But it would be nice to contribute. It's nice because you learn other people than just the speakers, and you get some more experience in what it is on the working floor, what we're talking about. So I would ask you, when we go into the breakout rooms, to turn on your microphone or your camera too, that would be even better, to just briefly do a round of introductions, say your name, your country, any experience you might have with Safety 2 or the theme that we've just been talking about, and then discuss with each other what the speakers will have asked you to discuss with each other. So that's about the breakout rooms. There's a conversation box on the right side. I see some people have already been putting stuff in there. Helgi from Iceland, welcome back. So please use that conversation box to add questions or suggestions. After each breakout room, we will come back with a plenary discussion in which we will try to answer some of the questions that you've put into the conversation box. So that is what we're going to do today. So let me just go to the speakers, and I will ask Mary to introduce herself, then Axel, and then Jeffrey, because Jeffrey will go on with a brief introduction on what Safety 2 is. Mary.
So good morning, everyone. I'm delighted to be joining you today. My name is Mary Patterson. I'm a pediatric emergency physician, also Associate Dean of Experiential Learning, and as of tomorrow, Interim Chair of Emergency Medicine. So I have a lot of experience, real life, with adaptability and resilience engineering. So delighted to be joining you again.
Delighted to have you here, Mary. Thank you for joining us. Axel.
Hello, I am Axel Roose out of Jönköping in Sweden. My professional background is that I'm a surgeon. I don't do surgery anymore. I am the Chief Medical Officer in the region Jönköping County in the southern part of Sweden, and I also do some research and teaching in patient safety at the university here. Thanks.
Good morning, good afternoon, good evening. I'm Jeffrey Braithwaite. I'm Professor of Health Systems Research, and I direct the Australian Institute of Health Innovation in Sydney, Australia. I'm also President of ISQUA, the International Society for Quality. And although I trained in psychology, I don't describe myself in that way. I'm really a health systems researcher with a great interest, a real genuine interest in safety and improving health systems. And my research is in those areas. So I think I'm invited by the moderator to continue. So I'm going to show some slides really to come to grips with some of the concepts that I think we're going to be workshopping during this session in a bit more detail, especially in the rooms, in the breakout rooms. So that's the title of the session. And the faculty is, of course, the people who you've just been introduced to, the four of us, and these are some of the institutions and organizations that we belong to. You're going to be hearing from three presenters who are presenting to us via video. Professor Kazu Nakajima from Japan, Professor Andrew Johnson from Australia, and Dr. Nikki Damon, who is from the Netherlands. And each of them has an extremely interesting, and even despite only a 5-minute video, a profound understanding of safety 2 and resilience engineering applied to healthcare. So we're going to be hearing from those shortly. So just a few more words from us, really to tease out some of the concepts and perhaps tease out some of the misconceptions about some of the terms that you'll hear and that we'll use in this session. One is a few words about reliability. The best place to go to for information about reliability is the IHI. Here's directly from the website. It's in quotes from the IHI website, which is in turn from Nolan's wonderful book with colleagues, Improving the Reliability of Healthcare. So the IHI believes that applying reliability principles to healthcare can remedy defects. It can increase consistency. It makes for better healthcare processes. It improves appropriate care and improves, in turn, patient outcomes. And IHI is working with lots of hospitals across the world, as you know, and really these are 3 things that it's trying to do: prevent failure, identify and mitigate failure, and redesign processes so they're, if you like, failure-proof. So that's, in a nutshell, reliability. It's to ensure consistency. Resilience, on the other hand, it's another R word in the English language, but it has a different flavor about it. Resilience is about keeping on, despite all the things that healthcare can throw at us, all the things that a health system can encounter, disturbances, changes that can affect the system and how it delivers care, whether we mean the system as in a microsystem, a team, or the entire health system or a whole chain. And it keeps on keeping on. It sustains required operations. And the best example recently is the pandemic, COVID-19, which the health system in many countries endured, and in other countries did extraordinarily well to flex and adjust and adapt. It's about adaptive capacity. So now the other confusion sometimes is about safety 1 and safety 2. And these are closely related terms to resilience engineering. So safety 1 is the way we've traditionally done safety. It's where the number of adverse outcomes is as low as possible, trying to stamp out harm, trying to make sure things don't go wrong. Safety 2, on the other hand, is where the number of acceptable outcomes is as high as possible, trying to make sure things go right more frequently. And so until we in the Resilient Healthcare Net, and Axel and Mary and I are members of that network from the very start, until we did that in the Resilient Healthcare, few people had actually asked the question and looked at, why do things go right so often? And even today in 2021, might I say, it sounds like a strange question. Why do things go right so often? Isn't the question, why do they go wrong so often? Well, that's safety 1 thinking. And what we help to promulgate is the idea that things go right a lot, and we should learn from that. We should understand that. So if you want a snapshot slide, this is the one. I'd like to claim, perhaps extraordinarily for some people, that the amazing thing about healthcare isn't that it produces adverse events in 10% of cases, although that's remarkable and obviously something that we have been working on and need to work on further. But the amazing thing about healthcare is, in a system this complex, it produces safe care in 90% of cases. That is remarkable. So that takes us to the work that's done about when things go wrong. And there's lots of that work: inquiries, incident monitoring, RCAs. But when things go right is the full picture and the most common picture of healthcare. And we had decided all those years ago, when we embarked on safety 2 and resilience engineering applied to healthcare, to understand that and do more work on when things go right. So just briefly, if you think about it, you can say this. You could say 40% of care is in line with guidelines or level 1 evidence. You could say 30% of care is wasteful. You could say 10% is the rate of adverse events. Or you can flip that and say 60% of care is in line with guidelines and level 1 evidence, 70% is well-deployed health expenditure, and 90% is the rate of safe care. So these are the two different perspectives in resilience engineering in Safety 1 and Safety 2. So just by way of concluding these introductory remarks, if your mental model looks like this, if you think about healthcare in its structural sense, then you'll tend to think about reliability and consistency in your approach. If, however, like us, you believe healthcare is better described like that, with lots and lots of interactions and lots of resilient practices going on all the time, then that takes you to understanding a response in terms of resilience. So that's really all we wanted to say by way of introduction, except that you're behind in your reading because we in the Resilient Healthcare Net produce books faster perhaps than many people can read. We're up to book 6 in the Resilient Healthcare series. So if you are behind in your reading, you need to get reading. And this, we hope, is a launch pad for you in this session to look more to Safety 2 and Resilient Healthcare. So now we're going to do the first of the videos. Just before I do, just a reminder, Safety 1 we've spent a lot of time on. And these are the kind of solutions under Safety 1. Root cause analysis, hand hygiene, medication safety, accreditation. We think all of those things, notice the bullet point at the end, insert your favorite tool, approach, or model there. We think all of those should continue. Safety 1 shouldn't be stopped. Safety 2 doesn't mean stop doing Safety 1. It means in addition to Safety 1, you need to do Safety 2. You need to do things more things going right. So that's all we need to say by way of introduction. There's lots to say in the small group work and in the rest of the session. Professor Kazuo Nakajima is one of the leading people in the Resilient Healthcare Net and one of the leading people not only in Japan but in the world. And she's prepared a short video. I'd like you to look at a few things. This is a story of everyday clinical work. It's a research project that Kazuo is leading. It asks, why do people fail and why do they succeed? The particular example is a pharmacy department dispensing. It shows constraints and disturbances and adaptive tactics. And we'd like you to think about that as you go through Kazuo Nakajima's presentation. May we see that, please?
Hello, ladies and gentlemen. I'm Kazuo Nakajima. I'm talking about understanding of everyday clinical work for quality improvement by redesigning the system based on Safety 2. Safety 2 is a synthetic approach to safety management, pursuing how people achieve intended outcomes in a changing environment and under constraints. We need to understand everyday clinical work focusing on interactions of individuals or subsystems instead of analyzing an incident. We targeted everyday clinical work, specifically medication dispensing and deliveries from the pharmacy department to inpatient wards, although the project was triggered by a medication dispensing incident. We focused on interactions between the two subsystems for medication administration on time. In the medication dispensing unit, workflow is like this. Major constraints in this environment were the limited number of pharmacists and the limited time for medication dispensing and verifications before medication trains leave. Significant disturbances were frequent interruptions of pharmacist work by answering phone calls and handing over medications at the pharmacy counter. We found 3 tactics of pharmacists to adapt to this environment to get the job done. The first one is staffing support from other units within the pharmacy department to complete medication dispensing and verifications by the regular medication delivery time. The second tactic is an increase in the processing power of a particular pharmacist. For example, pharmacist A stretches his capacity of verifications a day, which was by far the best. The third one is navigating a constraint in other systems. The pharmacy department runs medication delivery trains to inpatient wards only 4 times a day because pharmacists need slack in their performances. On the other hand, in inpatient wards on the right side of the slide, nurses also worked adaptively. When physicians ordered urgent prescriptions, nurses often made phone calls to pharmacists to request urgent medication dispensing or inquire about the delivery time. They also picked up medications at the pharmacy counter. Because there was infrequent medication delivery, no information about the progress of medication dispensing for nurses, and no alternative to medication pickups at the pharmacy counter. As a result, pharmacists were interrupted by phone calls every 4 minutes and counter services every 11 minutes. That is, frequent interruptions in pharmacist work are emergent problems from interactions between the different subsystems of the hospital. To solve such a systemic problem, we implemented 3 interventions colored in red to mitigate the constraints in inpatient wards. Visualization of the progress in electronic patient records, extra medication deliveries by trains when needed, and the use of lockers for medication pickups. After the interventions, the numbers of phone calls and counter services have been significantly decreased. Here is the summary. People work adaptively in a given environment. Adaptive tactics make the system function well, but at the same time, they have potential risks for failures. Describing how people work can help identify systemic problems and their solutions to redesign the systems for quality improvement. Thank you very much.
Okay, thank you, Professor Nakajima, and I think you might even be in the audience. Thank you for preparing that fantastic short summary. So we're going to put you in small groups now, and we don't have any complex, 10 questions to ask you. We really want to see the energy of the small groups and see how you might respond to what we've said so far. So you'll be put in small groups 3 times, as Ian has said. So in this first one, could you just react to that and think through with your small group in the rooms how this might apply in your own world? And particularly, I guess the question I have is how can you use examples like this and the words that I've said to do more things going right in your setting, in the work that you do?
So Ian, you were going to ask a question first, correct?
Yes, that's right. And I can see that we have our delegates back with us. Mm-hmm. So welcome back from the breakout rooms. There are 2 questions. One question from the group. Jeffrey, you were talking about these books that you produce faster than we can read them. Where, if we want to read them, where can we get them?
So the books are available on Amazon and easy to procure. There's also some summaries of these concepts that I've been presenting on behalf of Mary and Axel. There's a paper in the International Journal for Quality in Healthcare called Turning Patient Safety on Its Head, which I think summarizes quite well some of these concepts. There's a white paper that was produced by the late Bob Weers, Eric Holnagel, and myself a number of years ago, and lots of the concepts still remain. So if people wanted to start some reading or just add some texture to their reading and not jump into all those books straight away, they could do so by those means.
Yeah, and I think if you Google Braithwaite white paper safety 2, you'll probably find it.
Yeah. And there's lots from Holnagel too. Eric is really one of the major producers of some of the concepts here, and there's lots from Holnagel. Yeah.
Super. Thank you, Jeffrey. So a question I have, you said that safety 2 is not meant to come in the place of safety 1. Safety 1 is important. We need the things that we have done to make healthcare as safe as it is now. But do you have any examples of safety 2 interventions that have been working so well that you can actually stop or reduce some other safety 1 interventions?
I think the sense of the resilient healthcare net and us, and I'd actually ask Mary and Axel to answer that question too, is we're not trying to stop safety one. Safety one and two are, if you like, a composite package. You will do safety one when necessary. And there's quite a number of papers in the later books about the fact that we shouldn't stop safety one. There's some legitimate reasons why you want to try and do reliability, try and reduce harm, do safety one activities. But safety two is, if you like, a much more look at the whole system. A quick answer to that, and I'd rather have Mary or Axel address this if they wish to. A quick answer to that is, look, everyone does root cause analysis, okay? When there's a sentinel event or a serious event, people will do a root cause analysis. A very powerful safety two question to add, and that's a safety one paradigm. How do we make sure that never happens again? So a very powerful question to ask during an RCA is, how many times did this happen, this procedure, this way of doing things, which created the error, which produced the error, or is associated with the error? How many times did that happen when it went right? And what can we learn from that? So you can even do safety one things, such as RCA, root cause analysis, but ask a safety two question. So we see them as complementary a lot. Yeah. Mary, Axel, would you like to add to that?
I agree. I agree. I would say you have to do both safety one and safety two. And safety two is very much about understanding the real work that's going on in reality. And so the safety two approach helps when the safety one approach isn't accurate enough for the complexity that was on one of your slides there, Jeffrey.
And I would echo that. And you may have seen Terry Fairbanks, who's an emergency physician at MedStar here in the States, was put in charge of a series of RCAs regarding people with spinal issues that had developed weakness and required emergency MRIs, essentially the kinds of things like epidural abscesses and those types of things. And he was tasked with looking at a series of cases. But what he did actually was asked to see the last 10 or 20 cases when there had not been a problem, when things had gone well, when things had gone right. And he was able to look at what the resources were, what the timing was, all those issues that enabled most cases to go well. And one of the questions when I'm involved in an RCA where I'm asked to attend, one of the questions I've started to ask is, so what else was going on when this happened? What other conditions, what was the environment? Because, oftentimes, to your point, most of the time this goes well. And so what is it that enables these things to go well? And what were the conditions that were different this time?
Super. Thanks, Mary. I just saw in the chat an excellent takeaway from one of the groups. Let's focus on the Swiss cheese and enjoy it rather than the holes. I hadn't heard that one before. Thank you, Lisa, for sharing that. Mary, can you go on and take up the presentation?
Thank you. So again, good day. I'm glad to be here. I have the pleasure of introducing a video by my colleague and friend, Andrew Johnson, who's a physician in Australia. He served as the Chief Health Incident Controller at Princess Alexandra Hospital in Brisbane, and he was charged with preparing that regional healthcare system, a tertiary care healthcare system with respect to COVID preparations. And his video, what I'd like you to pay attention to is his description of the resilience potentials and how he describes their flexible plan, which gave the system and the people within the system space, what we call margin for maneuver. And the third thing that I think was really important in Andrew's video is how they valued frontline healthcare workers. The agency they gave them, they allowed them to exercise their full competence envelope. Particularly, he talks about a goal-oriented rather than a task-oriented approach. And this is something we view as very important in terms of frontline healthcare workers and their agency. As well, they learned from the frontline healthcare workers during as they prepared and during COVID itself. And one of the questions that I've been really pondering throughout the pandemic in my own work and when I hear about others' work is, why were frontline healthcare workers able to exercise agency in ways that we typically are not able to exercise agency during the pandemic as compared to our usual work? So with that, let's please take a look at the video.
G'day, I'm Andrew Johnson. For the first 6 months of 2020, I was health incident controller at the Princess Alexandra Hospital in Brisbane, Australia, one of Australia's largest quaternary institutions. In that role, it was my job to prepare the organisation for the expected influx of COVID-19 patients and for the impact of COVID-19 on hospital operations. To achieve that, I utilised the resilience potentials described by Holnagel of anticipate, knowing what to expect, monitoring, knowing what to look for, responding, knowing what to do, and learning, knowing what has happened. In anticipation, we needed to look at the international experience, understand what was happening to our colleagues around the world and the behaviour of COVID-19 down to an individual patient level and at the hospital delivery level. We developed flexible plans around that international experience. In monitoring, we needed to explain those expectations to our staff so that they knew what was expected to occur and were able to advise us when things were not going according to plan. In sharing the plans and the information as it came to hand, we were able to turn our 6,000 staff into 6,000 monitors. In responding, it was critical that from the Emergency Operations Centre, we didn't try and direct specific actions required at an individual or departmental level, rather to explain the outcomes that were required so that those that were working at the coalface, who understood the work that was required and work as it's actually done, were in a position to create emergent solutions to deliver against those challenges. In learning, we needed to apply the safety 2 principles of establishing what goes well, not just what goes wrong. And we did that in real time, looking at reflecting in action what was occurring within our organisation so that we could do more of what goes well and less of what was not working. The results spoke for themselves. We were able to triple our capacity for receiving emergency patients, triple our capacity for intensive care, and create a 150-bed buffer within the organisation to deal with the expected influx. We're very proud of our results.
Super, great. Mary, would you like to give people something to talk about in the breakout rooms?
Yes. So again, just to reiterate, I think what we heard from Andrew is that they deliberately chose to use the resilience potentials. And I particularly like his statement about they turned 6,000 staff into 6,000 monitors. And again, that speaks to their trust and belief in the ability and expertise of their frontline healthcare workers. And again, I think many of us saw that or saw parallel actions or parallel experiences during the pandemic as well. And it was, to many of us, very different than how we usually see healthcare working. And so I would ask people to think about their own healthcare experience, their own healthcare systems experience during the pandemic, and think about how their frontline healthcare workers reacted and how does that align with these resilience engineering potentials, and also the idea of the trust and expertise of the frontline healthcare worker.
Great. Okay, Hannah, can you break us up in breakout rooms again, and we will reconvene in 7 minutes. Okay, well, thank you guys for doing the breakout rooms, and I hope you had good discussions. There were some questions that were posed during the video also. So here's a question from Reines from Latvia, who I know personally, but that doesn't really. Anyway, would you agree that gathering everyday data, when most situations are probably dealt well, of performance is a way how we can implement safety too? So, do we need the data on what's going well?
So, I think that one of the things that speaks to is, and maybe it's not data as we think of like how many of this and how many of that, but more about understanding each day or regularly at least, and one could think of this as a huddle or something along those lines. But the idea that the front line has an opportunity to get together.
It seems like Mary hasn't come back. So Axel, do you want to take that first?
No, I can see Mary.
Mary's on.
Mary's on.
Oh, okay. But what I see is if people have the opportunity each day to reflect, if you will, on what we did yesterday, what surprised us, how did we manage it, how did we do that well, or if there are opportunities for improvement. But that, again, creating space for reflection, and again, and learning from the events, the everyday events, as well as what surprises us or the disturbances in the system. I think just creating the space for the interaction to occur, whether that is based on qualitative data, that is talking to the frontline healthcare workers, I think that might be more valuable than actual numbers, but actually creating space for reflection with the teams, with the microsystem, I think is incredibly valuable. And that's something we did, of course, during the pandemic.
Yeah. And Axel, maybe you could say something about, because I think the Swedish quality registries could be seen as a form of a safety tool, way of gathering everyday data to look what goes right and learn from that.
I was thinking about that myself, and that was this question about quality as something that you can refer to when it comes to safety to approach. But I think that those are good for overall measures, but still, as Mary was pointing out, still you have to understand what sort of behind those the good quality measures or indicators or results you have. And the only way to do that is to really sort of build up the knowledge of how work is performed in everyday work. I wouldn't say that general data is useless, but they are useless if you don't also reflect what's behind those data. And of course that's a bit problematic in management in healthcare, to sort of, because for management you have to have the overall general data, but still they are built on what's sort of happening down on the floor.
Yeah, I know what you mean, Axel. I work at a regulatory authority, so not everybody likes us, but and we are seen as one of the drivers of this kind of the bad form of data. But we are switching more to what we call narrative accountability. So we're not saying, oh, we see that your data isn't as good as the rest. We're saying, well, this is your data. Can you tell us what does this mean to you, for your context, your situation? And those are very different conversations than we used to have a couple of years ago.
And that's sort of one answer to one of the other questions in the chat about laws and regulations and safety too, because that's what you are describing then, Ian, isn't it?
Well, it's not the law, but it's the way we supervise and scrutinize the healthcare quality. Yeah. So the question was indeed, and maybe that's one to put into the group. How do you see it happening that safety 2 concepts will also be embedded in laws, like many safety 1 concepts are, or does that not fit?
Actually, it's not in a law, but it's in one of the regulations in Sweden, where it says that we should learn not only from patient harm incident, but also learn from things that go well. So yes, it's in one of the regulations actually.
Okay, that's nice. Looking at the time, Axel, would you pick it up and do your presentation, introduce the next video, please?
I'm pleased to. And the next presentation is sort of quite close to this topic, because it's how do you perform safety 2 on a national level or on a healthcare systems level. And Nikki Dammen, who is also is in the audience, I know. I can't even sort of pronounce or say what she was working with or working at, because that's in Dutch. But the next video is made by Nikki, and based on the essentials that we have been touching, the need to understand the adaptations in daily work, the difference between work as imagined and work as done in the daily work, and how you have to learn from the front line and learn from the good example what works well. How does that translate into national patient safety initiatives, which in a safety 1 world is very much about national guidelines and also legislation about incident reporting systems and that kind of stuff. How do you transform that into national learning system based on what goes well? So while seeing this video by Nikki describing how this might be done in the Netherlands, I ask you to reflect on would this look like where you work? So can we please have the video?
In 2017, I traveled to beautiful Sydney in Australia to learn more about the Safety 2 perspective and the FRAM method at the research department of one of the great founders of resilience in healthcare, Professor Jeffrey Braithwaite. After years of research on guideline implementation and causes of errors in quality and safety in care, this was a relief for me. Finally listening to and learning from the one thing it all starts with, the healthcare professionals in daily practice at the actual workforce. I conducted my first FRAM analysis on perioperative anticoagulation management at a cardiothoracic department in Australia, in close collaboration with one of the university hospitals in the Netherlands. And highly, but then really highly inspired, I returned home after 8 wonderful months down under. And also with a personal mission. This Safety 2 perspective should spread through healthcare in the Netherlands as well. And from that day on, in my view, it was the only way forward. My name is Nikki Dammen. I'm a program advisor at the new Dutch National Quality and Safety Program called Tijd voor Verbinding, or in English, Time to Connect. In these few minutes, I would like to tell you more about the program and how the Safety 2 perspective also in the Netherlands goes national. In Tijd voor Verbinding, the Safety 2 perspective provides the base. We focus on 3 main themes: anticoagulation management, the vulnerable elderly, and the multidisciplinary conversation among healthcare providers. And within 4 years, we strive to further improve the quality and safety of care on these themes at a national level. But rather than implementing some more guidelines, as previous national programs mainly did, we literally aim to connect all hospitals, all private clinics throughout the country. We take a Safety 2 approach and stimulate organizations to share good practices that exist on our teams so that others can learn from them. Further, we inventorize their wishes, their needs on quality and safety of each hospital and private clinic. And we stimulate and help them to learn from suitable examples of other organizations. We build new networks if necessary and use already existing networks to facilitate a national learning community. We try to inspire, actively connect and guide organizations to take the next step in quality of care and patient safety. And we do this together with our healthcare professionals at the actual front line. Within Tijd voor Verbinding, besides our main teams, we also provide inspiration sessions and advice on how to spread the Safety 2 perspective within a hospital, within a private clinic. And globally, what we see is a mixture of mainly applying tools, such as FRAM or video observation, versus taking a broader perspective, and then we inspire an organization as a whole within the Safety 2 perspective, and then they want to implement a hospital or clinic-wide approach. And within the upcoming years in the program, we strive for all hospitals, private clinics, to get to know more about what the Safety 2 perspective can offer and how it can change their view on quality and safety. Make it more fun and bring it closer to the healthcare professionals at the front line. So to conclude, as 3 minutes go very, very fast, I would like to thank Jeffrey and his team for the opportunity to have a little contribution to their symposium and the IHI conference. And in the Netherlands, as I speak for myself, we won't sleep until every of our 70 million inhabitants get the message. The application of the Safety 2 perspective is what we should do. So thank you for your attention and enjoy the rest of the conference.
So at this moment, we are going to let you out into breakout rooms again, and please reflect on what you heard Nikki telling you about, and also discuss that if you believe, as we do, so deeply in the Safety 2 approach, how would you work with the spread in the organization where you work? Please.
And we will reconvene in 8 minutes.
Hey, dit is een stom. Ik zat net bij Ian.
Ja, die kwamen kijken, die rooms volgens mij.
Oh, oké. Hi.
Hallo. There are 11 people.
Yeah. Before we had also just
We start with the 3 of us.
I think that's okay.
Yeah.
Because Nikki and me, we know each other already because we work at the same program. So
I just told you about it. So, Kira, what did you think?
I'm Jared from Northern Ireland. So I work with the quality improvement team in the Southern Trust in Northern Ireland. Yeah, so we would adopt a lot of these approaches where we work. We link it in with our human factors courses, which is all about understanding the system that's actually operating, to understand the outcome that we're receiving. Yeah, so we would often have the mantra of sort of encourage the behaviors that you want to see. So it's about recognizing when things actually go well. So we wrote out an initiative called the Great Text. So it's about just sort of recognizing and sort of when good practice actually happens, whether it's a good catch where we catch something before it actually happens. And it's about encouraging that people will actually look at all the things that go well in the system, as opposed to always looking for fault, because we have a culture of sort of we always have to have someone to blame, and that feeds into the culture of an organization, that somebody's always looking to find a piece of information that they can blame on someone else. So it's trying to move everyone away from that, to understanding that problems will happen, and let's embrace that, and let's actually look at how do we make the system better for everyone.
Yeah, it sounds very great, very nice. And how do people in your organization respond to that?
It's hard, actually. So it's not as easy. Everyone wants to do it in theory, but in practice, it's still a lot harder. And it's something that just takes time, and everyone's so busy. So we're trying to get people to find the time to actually stop and pause and reflect on all the things that we're actually really good at. So it's like everything. When we work with groups, it's easier to get them to tell us about all the things that aren't right, as opposed to all the things that are actually going pretty well for them.
It sounds very nice, but my experience is also that there is a lot happening on reflection already in hospitals and clinics, but they don't, and that's I think the core of the safety tool perspective, because you reflect on the whole picture instead of just the whole path. So, and that's I think a challenge for a lot of healthcare professionals, but also I think there's a lot of happening, but they don't know that they should look also to the things that are going right. What's your experience with that? Like when you look at reflection moments, what kind of initiatives are there? Oh, I see there are just
30 seconds.
30 seconds left.
Thought we had 8 minutes.
Yeah, it's very short.
Yeah.
It's something that we want to bring in more. We often do initiatives through time out for teams. Is an initiative that we do with specific teams to get them to look at their pathways, and that's something that we build in to those workshops about looking at how well we're doing and sort of being sort of thankful and grateful for the things that we're actually really good at. But yes, it's tough whenever everyone still works in their silo and they kind of look at just their department or their wee team, but they interact with so many different teams, and it's hard for them to actually figure out. The particular hospital we work with is everybody's related to everyone, so this sort of our area is sort of everyone is a relative of somebody, and there's so much gets done through different relationships, from fixing a broken tap to getting a new table. We all have connections, and we don't value that we actually have those connections, and that's how we get things done. So my wife works in IT, and my cousin works in the estates. So people come through me to get things done, and that's how our system kind of works. It's not written down.
Okay, we're all back. Thank you again for the plenary discussions. I was in one which was very, very insightful, and one of the things maybe I'll put it before the panel. So safety 2 is about talking about things that go right, but some people are so used to talking about things that go wrong that they get a bit uncomfortable when they start getting compliments from people, like, you did this really well, and I think, okay, why are they saying this? What's wrong that they're telling me that I did something well? So have you also, maybe it's a cultural thing, but does that resonate with you, that it might be something you have to learn to accept compliments and to talk about things that go well?
I think it is a cultural thing, and I think that is something that you have to train. We have some experience from that here in Jönköping, where we have tried to introduce daily huddles, supporting learning from everyday work and what goes well. And you're right, Ian. We are raised in a tradition where we reflect on mishaps and bad events. So it really takes some time, and it's a cultural thing. And people are also a bit, shy about talking about things. They sort of blush when they have to reflect on what goes well. So that's something it takes some time. But once you get used to that, it really builds. It also helps to build a good supportive culture, moving away from a culture that's marked by punishment and penalties.
Yeah, I would agree with that. I think that in healthcare, we do have a tradition of really looking at the negative and the mistakes. And so it goes against the grain and how we kind of grew up and were trained in healthcare to look at the positives. And I think, especially for people that perhaps are not used to doing this, it sounds silly, but we actually give them just some simple cues or questions to ask in a way that will provoke a discussion about why certain things went well, or what were the constraints, what were the resources or the team behaviors that enabled or facilitated things to go well in a particular situation. So I agree. I think it's sort of our culture and I suspect that the culture is in healthcare with respect to that is international, because we've all grown up around Safety 1. For most of us of a certain age, we grew up with Safety 1, and Safety 2 was new.
It doesn't necessarily have to be all praise and wonderfulness, though. There's a very tough-nosed way we can approach this, and I think we should sometimes, which is, the classic drive to succeed that's inherent in medicine and the other health professions too. So we don't have to necessarily be praising everyone all the time, but the drive to do more things right is equally legitimate, and perhaps even more so than the drive to root out error and harm, because that almost always, even though we've said we're running a no blaming system, that Safety 1 often leads to blame, and we don't want to do that. We neither want to blame nor excessively praise. We just want to deliver better healthcare to patients, and the balancing factor of not always looking at things going wrong, but looking at how things can go right more frequently, more often, can be quite hard-nosed.
Yeah. Mary, you wanted to add?
So I was going to say, and it doesn't need to be, and mostly it isn't about individual praise. It's mostly around what enabled us, what made us able to do this, what were the conditions, what were the resources. Yeah. So less about, you did a great job, and of course some of that is good to have some degree of that, but more typically we're looking at the system and the resources and the constraints and what enabled the team to succeed in this situation, or on this particular day, relative to not really relative to one individual, because it's almost always not one individual. It's the entire team.
It's very much about to understand that there is a learning from everything that goes on. And that's very much back to Jeffrey's slides in the start, and there's a comment by Nikki Dammen here also on the conversations about that there's a learning from everything that goes on. So it's praise is nice, but praise is not the important thing. Is to understand that we also have to reflect when we succeed, and we succeed most of the time.
And look, if I can reflect on Axel and Mary's work, Axel's work on microsystems in Jönköping, looking at the unit of analysis of the microsystem, not the individual, and how it can succeed. And then Mary's work with Ellen Deutsch, especially on simulation, looking at how the team in a simulated environment enables good care, and then transplant that into the workplace, into the clinical setting. These are very strong models for not looking at individuals, but teamwork, and how it makes care succeed more frequently than it fails.
That's a nice bridge to one of the questions that somebody asked. Rex asked a question, and Rex is also practicing by giving us a compliment. So thank you, Rex, for that one. But so he says, and is there any way to measure resilience? So we heard Nikki's story about a whole national program, and you've given some examples of a specific intervention that you're doing. But what are your thoughts about measuring if it works, if the healthcare gets better, or if you're doing it right?
Well, you can't really measure resilience in hard facts or hard figures. resilience is something that is done in an organization. So what you can do is that you reflect on how things are done, and that there are tools for that sort of helps you to describe how you do resilience.
Okay. Mary or Jeffrey want to add to that, or shall we go to the next question?
I would just say, I think this is one of the real challenges for us is to Axel's point. We can't really measure resilience. It's dynamic, and I think that oftentimes in safety, our safety professionals oftentimes want some sort of metric or number, and that's really not what this is about, albeit many people ask for it. I think it's a challenge. I think it also is, we sort of know it when we see it, but to have a number to attach to it is really difficult.
Exactly. You know it when you see it, Mary. Can I just challenge you to explain a little bit more? So you're coming into a room or you're coming into a situation. How can you see whether they are working in the safety 2 kind of way?
So again, I'll go back to COVID and the pandemic. We were conducting in situ simulations, so simulations in the clinical environment all over the entire hospital, so in multiple microsystems, critical care. And what I observed was because of shortages, no one microsystem had the same resources, the same personal protective equipment, and within each microsystem, the frontline healthcare workers found solutions, a multitude of solutions that were adapted to their particular environment. And because we were doing this in multiple microsystems, we could see the solutions that were developed in these various microsystems that were sometimes similar, but oftentimes not. Yet the frontline healthcare workers had developed these, and this was clearly an example of safety 2 and resilience, because they were reacting to these disturbances, to these challenges. They were adapting solutions to the resources they had, as well as to their particular challenges in their environment. So I was seeing it, on a daily basis, even multiple times a day, as to how the frontline healthcare workers and the microsystems were adapting individually to their own context.
Yeah, that's a great explanation. It makes me think that there was this research done a couple of years ago already by in the VA, the Department of Veteran Affairs. They looked at their hospitals and they implemented the surgical timeout procedure. And then they went to check whether this reduced mortality and morbidity. And they saw that, and they also asked to have the surgical timeout procedure returned to them. So, and they saw that in those hospitals that had returned exactly the same timeout procedure as had been sent out 2 or 3 years before, there was no impact. But in those hospitals that had different timeout procedures, they actually saw this reduction in mortality and morbidity. And that kind of resonates with what you're saying, Mary. Is that correct?
Yes, that I think, the tools we have need to be adapted to the microsystem. So I think that when we think about, and I think that's what happened during COVID, we had goals rather than checklists, because we had to achieve patient safety, of course, but as well, we needed to achieve caregiver safety. And we had those two primary, if you can have two primary goals, those were the two overarching goals. But the various microsystems and the people within the microsystems achieve those goals adapted to their own context.
Yeah, thank you, Mary. Well, we're at the end of the session. It's 1:15. Just a quick round of the speakers. Anything you want to share to end it with? Can I start with you, Mary?
As always, I really enjoy these discussions with all of the people here and the breakout rooms. I heard things that were really interesting, and I always learn from everybody, and I appreciate that so much. Thank you.
Thank you. Axel.
Oh, I agree. It's all about learning. You learn when you go to you even learn when you go to a virtual conference, but resilience and safety too is very much understanding that there's a learning in everything that happens all the time, and as one of the questions were here, you have to sort of learn. We have to organize learning in the systems as well, not just for yourself, and that's very much about what this is all about.
Yeah, thank you, Axel. Jeffrey, you want to end?
I think it's a practiced art to look at how much the organization adapts, how much we facilitate teams to have a capacity to maneuver and to think about healthcare as a complex system rather than one that responds in a linear way to, if we do this, that will occur. And that's at the heart, I think, of what we've been saying today.
Yeah, thank you. Well, thank you again, Jeffrey, Axel, and Mary, for your great presentations and your insights. Thank you, Laura and Hannah, for helping us in the background. And thank you to all the delegates who've joined us today. And I hope this has been inspirational to you. And enjoy the rest of the forum. Bye-bye.